Welcome to Distance is No Obstacle, a medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia. Today's podcast is about voluntary assisted dying. This is the second of a two-part series.
My name is Alice Morison and I'm privileged to lead the WA Voluntary Assisted Dying Statewide Care Navigator service, and I'm joined today by Dr. Boo O'Brien and Dr. Sam Ognenis, GPs who have had varied experience both in supporting their patients at the end of their lives and as VAD practitioners. So we've talked a bit about the eligibility criteria and some of the practitioner roles, but I wonder if we might step through what the process would look like essentially for a patient. So Sam, how long-ish does it normally take?
It again very much depends on the patient and what documents we get through. We're very lucky that often as the VAD practitioners, by the time we're being asked to see someone, the Care Navigator services compiled some information already, so certainly demographic information, but more relevant and more usefully, say a letter or two from their GP or their oncologist, perhaps even stating about expected prognosis and that kind of thing. So that's really, really helpful to go in knowing that there is an expectation around prognosis, or that there isn't an expectation around prognosis, and that's okay too. The person is still entitled to have that first consultation and that review, and they may be deemed not eligible, but they at least then have that option explored, which is helpful. So that certainly saves a lot of the time initially, but a good initial review would take I would say half an hour at least usually. Can be a little bit less, can be a lot more sometimes, but essentially there's three sort of main touch points along the way. So there's, after that first request is in, there is then the coordinating practitioner who does what's called the first review, which is basically that initial assessment of eligibility, discussion. There's information that's required to be given to the patient for them to take away, think about, etc. And then there's some through the online portal that you get through the training, and or you can access it separately. Your role is to then submit that you've done the assessment, that you found the person eligible or not, and the next steps, which would then be seeing a consulting practitioner, which has to be someone who's independent of yourself. So, as I said before, they could be a subspecialist in the area, but they don't have to be. Other than that, there's a lot of options there, and their role is to essentially do a similar assessment to what you've already done, with the intention of checks and balances, essentially making sure that the person definitely does meet the criteria, that they agree, etc. They will often be able to answer some of the questions the person might have thought about in between the two appointments, and then at the end signing a written declaration of the patient's enduring request for VAD that's signed by them and witnessed as well, and that then goes back to the first coordinating practitioner. And their role is then to do the final review, which involves sort of discussions about administration, where, when, how, and what method that might involve, and doing prescriptions to the pharmacy service, etc. So those are the main three touch points along the way. That has to, that process under the law has to be at least 9 days apart, unless the person is expected to imminently die or imminently lose capacity. But as we said before, that's not the common situation. But that 9 days could extend out to weeks or months potentially. It's usually a few weeks, and then things sort of sit in idly until the person is ready, if ever, to access, and then you arrange administration and so on from there.
It's important to know that this is not a runaway freight train. The person is absolutely in charge of the process, and while there's some minimum timeframes our law requires that you mentioned there, Sam, there's no maximum time frame, and it doesn't expire. So a person can choose to take as long as they wish to work through the process. They can pause, they can stop at any point, and they're never under any obligation to actually use the substance. We talked about the two medical assessments that happen there, and considering WA is a vast and large place, I wonder, Boo, if you might talk to the use of video conference or telehealth for these patients.
It's a really convenient and good way to access especially regional patients, I think. However, we are restricted by the way I explain it to patients is that there's these three main visits what Sam has said, really. And, your first assessment is, say, I'm the coordinating practitioner. I'll do the first assessments. I can do that on video, and as long as I can see them, so it's video conference or telehealth, not on the phone. And only because sometimes things like assessing coercion and things, I find that still difficult on video. I would rather be with the patient and with the family around them. But with distance and sometimes we're rushing through it because of time, then, we do it this way. And then I often then explain to them that the second doctor, who's actually coming to check up on me and not them, to make sure that I've done the right thing by them, because they can be, they're actively sometimes dying and they're exhausted and they're wondering about why they're being checked up on. So that can also be done on video conference or telehealth, which is great. However, the final assessment, which Sam has described really well, cannot be done by video or telehealth. We have to have a face-to-face discussion. And that's because we're restricted by the Commonwealth Criminal Code Act of 1995, which sees us discussing, medication and how the patient is going to be given the medication, how they're going to die, etc., as really transmitting suicide-related material. So we have to do this face-to-face. The other part that we cannot do once we leave that assessment, we write the prescription for the medication, and sadly at the moment we have to deliver it to the statewide pharmacy, which is in Perth. So that's a big disadvantage as well, because we cannot fax it or email it. And again, it's based around this Criminal Code Act. So there are two things, I think, that really puts regional patients at a disadvantage. Just from, again, having, done some regional work, not as much as some of my colleagues, where I think regional patients are really disadvantaged by these two things, and also things like having to get to them for the face-to-face. Flights get cancelled in the morning to places like Esperance and Exmouth, and we, have just knowing that we have to do that final assessment, fly back, give the pharmacy the script, and then fly back again to the patient, and we've missed the boat for patients many a time.
You did mention suicide in there, and I think it's really important to draw a line under that, in that is a way in which voluntary assisted dying could be perceived in line with the Commonwealth Criminal Code. However, Western Australian legislation makes it abundantly clear that voluntary assisted dying is not suicide. It's just due to a funny quirk in the Commonwealth law in the way in which we relate to them. It's not about how voluntary assisted dying is considered in Western Australia. People may be aware there is a private member's bill before the Federal House of Representatives with Kate Cheney from Curtin, seat in Perth, in order to sort of separate that point out, so that the criminal code obviously should stay in place, but the VAD have a separate consideration. So that may or may not come into effect. As Boo said, it's not in effect now, so we have to work with the law as it stands. And there are things in order to make sure that as much as possible, rural and remote patients have access to the services. So there's the Regional Access Support Scheme, which would cover travel and or accommodation for practitioners and or the patient, either way, to access the service. And that also applies to the pharmacy service. So, for example, the pharmacy, if needed, and they will deliver medication directly to a patient or a coordinating administering practitioner in the country. It just means that there's more consideration. So as Boo says, that these are theoretical versus practical considerations, and obviously if things take a few days to happen, then that can cause an issue. So we certainly encourage people in rural and remote areas, patients and doctors, if you do get a request, speak to the Care Navigator service early,
they're very helpful. The pharmacy, very helpful, happy to take calls and to, push things along quickly, should that be necessary.
So both statewide services, the statewide pharmacy service and the statewide care navigator service, are designed to be mobile. We travel to see patients wherever they are across Western Australia, and that can be to help support someone through the process, and can also be to come and have a cup of tea and a conversation about what VAD is for the patient, but also to sit down with a GP practice and talk through what this might look like in their region and in their own practice. I wonder if you might move a little bit to the people who are very much firmly in the centre of this, and if we could talk a little bit about the patients, the humans at the middle of this, and what they're like. Sam, could you tell us a little bit about what your patients are like?
Yes, for sure. So there's quite a varied patient group. So you might have an idea of, ages or diagnoses of who you might expect. Might be involved in this process, but generally there's certainly a mixture of malignant and non-malignant conditions, age ranges, obviously 18 plus, but typically that could be anything from that age, 20s and 30s, through to 80s and 90s. I typically find what is fairly consistent, as I said earlier, as I'm sure as many other people's experiences, that patients are much less afraid of talking about death and dying than we are, and also perhaps families and other people are, and so often raising it and talking about death in whatever context, they're often quite happy to do that, and I find people very happy to talk. They'll tell us about how they got to be where they are, and their life experiences, and perhaps it's related to their experiences individually. It might be what they've seen with family members or friends at the end of their lives, and they're very happy to share those experiences, and it can be really rich, and it's a privilege, I think, for sure, to have this opportunity to provide this care. And I often say to people, families often at the end, I say, thank you very much for coming in. I couldn't do it. It's very hard. I don't know how you would manage it. But it's really, the patient is very appreciative. And usually I just say, look, the reality is, like most things in medicine, there's guidelines, and often we're bound to do, certain things a certain way, and we're sort of the quote unquote experts. When in reality, with VAD, it's mostly just what the patient wants, essentially. And that's why I enjoy doing palliative care, and that's why I enjoy doing VAD medicine, is that, the patient is centred, and, we find out, do they want to be in the garden? Do they want to be at their hospice that their partner or friend died at recently? Do they want to be, at the beach? All sorts of things, and dogs present, not present, music playing, not playing, all these kind of things. People have got such diversity of what they want and don't want, and if you just ask them, they'll be quite happy to tell you, and often can make that work. And we've had all sorts of experiences of how the administration goes. And yeah, from all styles of all styles of patient, all styles of setup and things like that. So
it is interesting, isn't it, that this really allows a space for people to make conscious choices about what it is that they want at the end of their life, including where they are and who's with them. And really what they're choosing is not, am I dying or not? They're choosing the manner, the timing and the nature of that death. In the lead up to the legislation, we did a lot of work looking at what the experience had been like in other countries and in other states, and essentially we were told it was going to be rich white fellas who were going to seek access to VAD, so definitely Caucasian people that were university level educated, very health literate, and that has absolutely not been the experience in Western Australia. We've had a vast gamut of humanity and different people from a vast array of backgrounds, but for me there is definitely some things that really unite them in terms of their nature, and I wonder, Boo, if you might speak a little bit to your experience in caring for people in that space.
Yes, certainly. I certainly find that we get all sorts of people from different walks of life, different ages. The two words that come to mind, and with discussion with families as well, from patients a lot of the time as we do the assessments with them, is control and choice. So they're patients who want control over their death and choice about when they die, how they die, because they know they're already dying. And one of the things about VAD is considering intolerable suffering, and intolerable suffering varies hugely from person to person. So, you might have someone who fits the eligibility criteria, and for them, they talk about the line in the sand, which is when they're going to actually access their VAD. And what I've found is this varies hugely. For some people, it's when I say, quote, when I end up in bed and I have to have a nappy on, and I don't want that. But for other people, they can be bedbound and be able to just move a finger, but they've got a 2-year-old child, and that gives them reason to. I've had a patient say to me, my goalposts keep changing. But so that brings me to the last word that is often used when we do the final assessment and we leave them to do the prescription. The word that's often used is relief, of having this, quote, in their back pocket, there if they need it. And the other thing that I've seen happen with this process, when this type of person asks for VAD, often family members are quite taken aback, can be sometimes, maybe not often, sometimes. They're upset by it because as a loved one, you want to hold on to your family member as long as you can have them, and you want to care for them, and you don't want to, it's hard to let go. But by the time we've got to the stage of final assessment and they can see how relieved their loved one is having this in place, and maybe, as Sam said, never having to use it, it brings them joy as well to know that this. And often I've had even patients who, and I'm sure you've had, who have not used VAD for various reasons. Maybe they've lost capacity and passed with palliative care, or they've just chosen not to, or the wonderful passing of just not waking up, which most patients say that's what they want. And then the family contacts us and says how much relief the whole process brought to them, this assessment and having it in place.
It's an interesting beast, and often I feel that once people understand what this choice is about, they're often not surprised that someone they love is making the decision. But it is a really important point, Boo, in that whilst you might really support someone's right to make their own decisions, you still love them, and we're rarely ready to let them go. And it can be a really difficult journey for families supporting someone through the process. And again, they often need the support and care of their GP to help them get through what can be an incredibly difficult time, both for the person but also for their loved ones. Which probably brings us really neatly to talking about the other people who are involved in the process, which is the practitioners who choose to do this work. And I wonder, Sam, if you would enlighten us a wee bit on why you chose to become a VAD practitioner and why do you keep doing it?
Yeah, for sure. So you mentioned earlier about the eligibility for practitioners being 1 year after fellowship, or perhaps if someone's not a fellow but has practiced for 10 plus PGY postgraduate years and have met other criteria. But for myself, finishing GP exams, had sort of sent in my information, and like some VAD patients was told, actually, no, you're not eligible at this time, come back in a year, which I did, and did the training, as I said before, have had a strong interest in palliative care and chronic disease for a long time, and thought that understanding VAD and being part of that process was a natural flow on from that, and as I'm sure others would have noted as well, the experience is much as much patient-centered care as you can get, really, in terms of learning about the patient, understanding where they're at, what they're like, what their life's been like, and what they want, essentially, and really not going in with any major assumptions, or at least having those assumptions challenged very quickly, and being able to provide that support. And so I tend to find, I personally, and this wouldn't apply to everyone, but I personally find a lot of other aspects of medicine much more challenging, much more where the patient is disempowered or is suffering significantly because of treatments that we've put in place, and we know that in the long term, certain medications will help extend their life and give them longer life expectancy, but come with risks and side effects and so on. And we're always balancing that day to day. Whereas in the case of VAD, we're really just providing support, care, and perhaps death in certain circumstances. But it's very much a patient-centered thing, and that makes it quite easy to do the work, I feel. But it is very important to have that balance and to do other things, to have your own GP, get support, reflect, not overload yourself and these sorts of things. And so we have a VAD community of practice where sort of monthly check-ins, either in person or on Zoom, and then obviously other interactions with other practitioners that are providing VAD care and getting that, as you said, mentorship, support, discussing cases, discussing your experiences and that kind of thing, just to normalise things and get that support and reframing things wherever you need to.
Yeah, I mean, a lot of what Sam says makes sense to me. For me, it was, I think a few stars aligning at the time. I had been in medicine about 20 years. 20? Yeah, 20. I lose track now. But
surely
and
over
it's
10.
25, 35, 45. No, nearly 30 years. Sorry, Alice. I'm making myself out to be younger. But so I was getting quite burnt out with GP work. COVID struck. I was really struggling in many ways. I was away from my immediate family in Malaysia. My father, who was an anaesthetist all his life, died during COVID time in Malaysia, and the borders were shut, so I couldn't get to him. He wanted to die at home, and my younger brother managed to get him home, but I spoke to him on the phone the night he died, and I knew he was suffering. But I knew he wanted to stay at home. So, but I thought it was ironic that he had spent nearly all his working life giving people pain-free journeys of their surgery and end of life, and he didn't have any. And I'd also worked in Ireland, England, Scotland, and here, and seen since I had graduated. And I realised, I think, like a lot of us medics do, as Sam mentioned, that end of life isn't without huge challenges from these intolerable suffering point of view. Sometimes if pain can be dealt with, then there's other parts of the patient's care that is really difficult to cover. So that it was a whole load of those things aligning for me. And then I had a little postcard, I think, in my pigeonhole, probably among 30 other bits, as Sam's smiling there, that we do every day. And there was something about, do you know about VAD? And I thought, what is VAD? I went to my practice manager and said, what is this? Can we ask someone to come and talk to us at our education Tuesday lunchtimes? And you came along.
I did.
And I remember sitting there, and I was actually in quite a bad place. I was sort of really burnt out, really struggling with many things. And I came up to you after the talk and said, how do I do this training? And so it was unusual in that way that, I just, and then I got COVID, and I was very well with it, because that was trying to factor in when I would do the training. I did the online training, but I was working a full week. So I got COVID, and I had my mandatory 2 weeks of being very well, and I did my training then. So, why do I keep doing it was that part of the question as well as, yes, I agree with Sam that it's such a, not easy job, it's so much less, takes so much less out of me and us, I think, Sam, than other aspects of medicine. There is still, and we'll probably talk about this, how you need to look after yourself, but at the end of the day, I think I just gained so much than I gave, and it's given me my mojo back.
It's beautiful to hear that not only is this giving patients choices, it's giving our practitioners something in return as well. But I think the well-being that you just alluded to there, Boo, is actually a really important thing to call out as part of this, because while Sam talked about the community of practice and the support that we all gain from working together in that collegial relationship, it is emotionally burdensome work, and it is important to be aware of your own wellness and your own well-being and how you're going to care for yourself. What's your feelings in the space, Boo?
Yes, I mean, everyone has their own ways of self-care. Some people have better supports at home, some don't. I factor in about every 3 months I take a break. So that might be 2 weeks, I've got a month coming up now, or 3 weeks coming up. So I know I'm always sending emails to the navigators going, by the way, in 3 weeks, I'm doing this, just so you know, I won't be available. That keeps me going. And I think psychological support for me as well. I've got a good old mental health plan, and I have a fabulous psychologist who I see for debriefing now and then, because I think as medics, this is never provided to us free of charge. We're used to this all our lives. But I think you really have to see whether you need it or not, because it's often something that you feel you don't want to talk to, apart from the confidentiality issues. You really don't want to spend a lot of time talking to your family about. And colleague support for me is really important. So I've started a Sunday group that meets at my house every, I don't know, there's no set time. It's 5 weeks, 6 weeks. I cook a curry, people bring bits to add to it. We might have a bottle of wine, and we talk about things ranging from difficult patients to our challenges to how we feel. And that works really well for me.
All the things there are exactly right. I totally agree. Having one's own psychologist, and I'm also conscious of the fact that our audience, it's an increased challenge on top of the fact that it's difficult for health practitioners to ask for help, get help, and continue getting help. But yes, I agree. Seeing a psychologist is very useful and very helpful for myself, and I guess also with seeing patients is trying to make sure that one doesn't put the VAD caseload just purely interspersed into your day. There'll be an element of that certainly with the paperwork and maybe initial reviews and things like that. But certainly, after like an administration or something like that, or when there's been a difficult conversation with someone, making sure that you've got some time to reflect and do something nice and relax for a little while afterwards, in order to I guess properly allow yourself to work through those that experience and those feelings and emotions and things. That's really important to emphasise.
And that's absolutely true, and something that's respected across practitioners and certainly within the Navigator service, about setting some boundaries about what's actually possible to do. There's an awful lot in there, but I wonder, Boo, if you were talking to someone who was considering doing the training or considering providing this care, what would you want them to know?
If you're wanting to do the training, and I think the training is straightforward. Once you want to do it, you'll actually find it very enjoyable to do. It's not hugely. There's not many barriers in it. Would you agree, Sam? So the training part is fairly straightforward. I think after that, my advice from how I've done it is find a good mentor if you can. And I must say, I've worked as a GP and a breast physician in the past and in different countries, but the support within the VAD community, the working community, is probably the best, I think, that I've ever worked in. So support from navigators and other colleagues. So I was really lucky to start with a really good mentor who is still a mentor and friend. And so start slow. I nearly said start low, go slow, like beta blockers, but start slow. It's all ingrained, isn't it? It's drummed into us. But start slow is a really good bit of advice that was given to me. And that's how I think I finished my training, and I shadowed my mentor on an assessment and consulting and a final, and then an admin. And then an oral admin and an intravenous admin, and just felt, allowed myself to sort of take it all in and see how I felt about it. And then she shadowed me on the same, so it's just giving each other that time and the confidence. And even now, when I have a patient that's going to be possibly difficult to cannulate, etc., we've got this little WhatsApp group, and people will come and give you a bit of support as well. So support, I think, and go at your own pace is the other thing. You don't need to rush it. You can choose to have 1 or 2 patients initially and then increase. So for me, I was still doing GP 3 days a week, I think, at the time, maybe 3.5. And so I wasn't taking on as many patients, but as this job has given me a lot more joy and it's just been a lot more fulfilling now for me. I've now dropped down to 1 day of GP. And same as Sam, I try and give myself 1 working day off, which sometimes doesn't happen, especially if there's an urgent admin to be done. But that's okay. It's still, I find it's easier for me to do my VAD on my VAD days and not be worried about GP. But when you're on your GP day, it's sometimes hard to dissociate from VAD, because patients don't stop needing admin, don't stop needing a call. And so that's juggling for me, is from that point of view, is putting my phone away and not checking my emails while I'm actively doing my GP work, because the whole multitasking goes out the window anyway, as we know, once we hit 50. So that's really hard. A good diary is a really good tip as well.
We mentioned a little bit about the kind of people who choose to access this, Sam, and I know our board do make public their reports every year in financial years, but I wonder if you might step us through a little bit about just the demographics around who made this choice in the last financial year.
For sure, yeah, very happy to. As you say, the VAD board has a report which you can easily Google and have a look, and sort of, I guess, headline kind of points to make is that for 2022-2023, that for most of the demographics, it maps the WA population. So in terms of sort of 70 to 75% of people requesting and dying residing in Metropolitan, sort of mapping the WA population at large. That there were 255 deaths in the last financial year, which is about 1.5% of all deaths in WA, which was a number that was kind of floated during the policy discussion and the experience from other places, sort of that 1 to 2% when you have these sorts of limitations and criteria. I think we would all expect that there might be initially some slightly higher numbers as there's sort of a quote-unquote catch-up, I suppose, of people who previously couldn't access, but I think we would expect that sort of 1 to 2% to probably be similar. That cancer diagnoses was about 73%, males to females was roughly balanced, 58% males, age range 30 to 99, the large spectrum there, and that about 80% were practitioner administration versus about 20% self-administration, and a huge range of demographics in terms of location, age, obviously male, female, sex, gender diversity, diseases, ethnicities, etc. And I guess to emphasise also that 86% of patients were receiving palliative care at the time of their VAD administration. So certainly, as we're alluding to, not an exclusion by any means, and actually a pretty good number. Perhaps it could be closer to 100%, but certainly a large number of people who are accessing care across areas, and not just rich white fellas, as you said.
Indeed. And I think, that 86% is the people who are accessing palliative care at the time of their first request. And because our law requires the conversation about palliative care throughout their assessment, I would suspect if we checked again at the end, it would actually be higher than 86%, which is pretty exciting. And the point that you mentioned, Sam, about population split and around the fact that the percentage of people who are choosing to access VAD is equivocal with where people live in Western Australia. So it's great for us, even though we know there are some barriers to access in regional areas, to know that the same percentage of people who live in Western Australia in regional areas are still able to access VAD is certainly reassuring to me, because that's a big part of the work that our service does. I'm conscious we haven't really touched on where you go for support, which is a key message really for us in this podcast. But really, for anyone who's listening who has questions about VAD or is supporting a patient through VAD or trying to respond to questions, just know that you can reach out to the Voluntary Assisted Dying Care Navigator service anytime. We're here to support patients and families as much or as little as they need, but also to support practitioners working in this space. So if you are just not sure how you might respond to a patient, or you want some resources for them, or you've just got some questions, or you'd like to refer refer them on to us for our care to help them find a practitioner to help them access VAD, you are so welcome to do that. We'd love to hear from you, and we're available Monday to Friday, 8:30 to 5, and I'm sure we'll pop some links down the bottom for you all so you know how to access us.
So check the show notes for the email and information, and that can honestly be anything, picking up on a little bit on what Boo said before about shadowing with the mentor, but also like my first administration, shadowing with one of the care navigators who was very experienced and everything was very calm and knew all of the things and knew what to expect, and it was all very very useful, both for the patient and their family as well as myself. So all the way through from just that initial where do I go for information, through to those more involved sort of hands-on support, but also practical things, where and when and how, accessing if patients need to be admitted to hospital, hospices, having services at home, these sorts of things that care navigators can help with navigating not just the VAD system, but also within the health system as well for us as well as for patients and families as well. So
perfect. So probably just to bring things to their nice conclusion, I think we should probably end right where the patients do, and the burning question that people normally have is around whether or not this does what it's meant to do. So in the patients that you've cared for, Sam and Boo, does this really give them a dignified death?
I think definitely yes. I think that giving the person more control, giving the person more of a say in their end of life, whatever that looks like, is important. As we've said many times, just asking and being part of the VAD process doesn't mean the person will die of VAD, but if they do, people are, I feel, in general, having a very peaceful death in a place that they've chosen at a time that they've chosen, with the people around them and the environment around them that they've chosen. And so yes, I definitely would strongly feel that people would feel that they're being given those choices and a dignified death, and for both the patient and their family. I think that's definitely something we've been able to achieve in WA.
Well, thank you both so much for being with me today and part of this conversation. We are incredibly lucky to have this person-centred option available for people in Western Australia, and I'm really grateful for everyone listening today who wants to inform themselves about how you can support your patients through this process.